everybody. Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. So, this is going to be an episode that's a continuation of what we are already started about APPs and their roles in modern healthcare. To recap, in our last episode, we talked a little bit about the origins of advanced practice providers and how that their roles have not just developed but evolved to become where they are now. We talked a little bit about how they started off as a way to bridge primary care health gaps, whereas now they are getting more compensation than previous. They're in all specialty surgical, medical, and hospital based fields, and in a lot of states, over 25 states, they're able to practice independently, all while having reduced hours of training as compared to physicians by a lot, by almost a tenth, if not more, and reduced duration of training compared to physicians, almost half, if not even less. And what we forgot to mention in the last episode is loan burden, right? They also are doing all of this very intelligently with less loans than what we end up with. Let's talk a little bit about where APP roles are now in current modern healthcare, and where we see the future going, and some questions that we should ask ourselves as physicians.
And I think the loan burden is huge too, because we're talking about almost half the time, the duration of years of training. So that means, they have half the loan burden or even less, I would say. They can pay it off even earlier. So in that regard, that's a huge advantage point, for APPs versus physicians.
Yeah, that's why I say they're very intelligently doing this, because imagine while we're students for all this extended period of time, we're not getting paid. Whereas if you're working as a bedside nurse, you at least have a savings account, right? You have a 401k. So when you take loans out, sure, you can pay them off faster, but they're getting to the point where we are practicing independently. The route that they've taken is not just shorter, but it's also more cost efficient. And I think they're able to do all of this because, again, the collective voice is there. They're unionizing, they're fighting for better working conditions for themselves. Whereas physicians, we've lacked in doing that, and increasing scope of practice for APPs, whereas, we're losing some of those spots to them as well.
Correct. So, I mean, yeah, as we said last time, there is pros and benefits to APPs, and there's cons that we think needs to be addressed. And so maybe we can talk about the pros and benefits of APPs. So I can name a few. So one of them is improved access to care. Definitely, it solved the problem of physician shortage, especially primary care shortage, especially shortages in rural areas. And that's why APP programs developed to address that shortage, especially in the era of a pandemic. And when we had COVID-19, that was a huge help to have APPs help out with the shortages. Often you can find APPs that are more available for appointments. Even myself as a physician, sometimes when I call to make an appointment, I can't get a physician to see me within kind of whatever months. So, but APPs are available, and I can make the appointment with an APP much faster than a physician. And you talked about the cost effectiveness. So for sure, from a hospital perspective, why not? Getting an APP and pay about 30 to 50% less than physicians. So definitely reduces their overhead. And so why not? They don't look at their years of training or things like that, especially from the hospital administrators. They look at the numbers, right? Then they look at the money. Money talks for them. So it makes a huge, difference for them. There are other things that I can think of. I mean, there are positive patient satisfaction scores for the APPs as well. Patients are not necessarily, some patients do want just physicians, but others don't care. They're happy. They're equally happy with APPs providing care for them. And many doctors also like the idea of having that support, APP support, especially with the documentation burden, so they can delegate their work and they can have a better work balance. Because if not, if there's no APP, they have to see more patients, and they're overburdened by documentations and things like that. So those are a few things that I could think of. I'm sure you can think of a lot more.
Those are all good pros. And I will say, like, the marketing for nurse practitioners has been great, where they say, heart of a nurse, brain of a doctor, right? That's like the big thing for them. And I think the general public also agrees. When I go on social media and I see these debates all the time, a lot of the patients would prefer to see a nurse practitioner because they feel like they listen to them more, they spend more time with them, they order more tests, which may be a good thing, may be a terrible thing, as we know, in terms of healthcare costs. But yeah, I think positive patient satisfaction scores, most physicians I've worked with, including myself, have appreciated having APPs when you're having so much administrative burden, right? Documentation, prior authorizations, peer to peer. It's nice to have like an assistant to help you. And I know they're more than an assistant, but it's good to have them. But there are also, some cons that I think we need to consider when it comes to APPs. So, for instance, like quality of care concerns, right? When you're doing less training, and you're doing less hours of training as well, there's going to be some variability in quality of care, especially if you're practicing independently. It's one thing if you're practicing under a physician and you know when to ask for help. But let's say you're just thrown into this. I mean, think about it. Like when we were interns, did we know what we were doing? No, I didn't. So I think, you have some of these NPs who are coming fresh out of their schooling or put into these complex, independent practicing models without oversight. And what do? You just order every test you can. You might not give the best care because, quite frankly, you need a lot of that education. You need that experience to become a good provider, because you just are missing that residency and fellowship. Piece. So you might overprescribe antibiotics, you might overprescribe opioids, you might order labs that are unnecessary. Your labs might show abnormalities and you might not know how to explain that to patients. So I think all of those quality of concerns, or quality of care concerns, are definitely a con.
It's like a first year resident, right? When we were
Hmm.
first year resident, we were uncomfortable with just being put in those situations ourselves. To go explain an abnormal MRI to a patient, or someone has a huge tumor that you're looking at and you have to go tell them. So situations like that, were difficult even for us as just 1 year first year resident. But we had 3 or 4 more years to do that, to get to that point, to learn, to see the complexities that come in our, for example, our specialty. And all other specialties are the same. But when the APPs don't have that, and it's very interesting to me how new graduates, if they're new graduates, are allowed to just go start their practice in specialties. I think maybe there needs to be talks about requirements of, for example, kind of primary care experience before going to specialties. Maybe that would help, something along those lines, that they can actually see the scope of practice. I mean, even for us as neurologists, we had to do 1 year of internal medicine before going into, for example, neurology specialty. So how come an APP new graduates can just choose whatever specialties they want to, and they can just apply for it, and most of the time they get it. Most of the time, they get those jobs. I work with some APPs that are new graduates and don't have neurology experience, so I did have to spend a lot of time educating them on things. After I provide a lot of education, I still feel that sometimes they're not comfortable with some things, especially like results, looking at MRIs and things like that.
So, one thing that I see constantly online when there's a debate between nurse practitioners and MDs is nurse practitioners will argue, yes, there are also crappy doctors. You can't just say that nurse practitioners don't know what they're doing based on a few bad ones when there's like a few bad doctors as well. You can't judge. But I guess my thought on that is yes, there are bad doctors. I totally agree with that. But when it comes to our training, at least there's like a set standard where I think with nurse practitioner programs that standard is missing. And like you said, maybe there has to be something in place that after you're done and after your new grad, maybe you do a year of family practice, a year of internal medicine just to kind of get your feet wet and get that minimal medical knowledge before you jump in to a specialty training. I mean, it makes no sense to me that you're a new grad and all of a sudden you're a psych NP. Like, I've managed some psych in my 10 years of being an attending, but I could not do that independently. So, how are they independently able to do that?
I agree. I mean, there are a lot of doctors that even we know some, right? That
Hmm.
we have to follow after them, and it's a mess, right? It's a mess. Patient care is a mess, and you have to, pick up and kind of clean up the mess. But and we have to look at the numbers. So just do face litigation. I mean, there is a huge medical legal risk with crappy doctors. So there is a standard. You can lose your license. You can, you have to answer to the board, undergo years of medical legal and litigation process. So I don't know if that exists within the APP community. I certainly know that APPs get sued also, but I think because their medical liability insurance is lower, much lower, so patients don't put a lot of focus on um, suing an APP. So they want the money, right? So you go sue a physician, a neurosurgeon, an orthopedic surgeon, an ER doctor, an OBGYN who has, you can sue for higher, much more money. So I think that plays a huge role.
Definitely plays a huge role. And there's going to be good and bad providers all over the healthcare system. But the point is, there needs to be a standard. There needs to be a standard because ultimately, these aren't easy decisions we're making. You could kill someone. There's a lot at stake. It's not like a low stakes issue. So I think definitely standardizing nurse practitioner training and PA training might make a difference moving forward. And I think PAs, I have to look into this, already have a specific standard of things that they have to do. But I think with nurse practitioners, it's a lot more variable from what I'm hearing. And then now there's like the doctor of nurse practitioner pathway, right? Which is fine. I mean, you're welcome to get a doctorate in whatever you'd like, but now you have DNPs introducing themselves as doctors to patients, and that's very confusing for patients as well.
I agree. Exactly. You have to clarify, what kind of doctor.
Because of all of this, there is workplace tension between physicians and APPs. Physicians feel like they're being replaced by lower cost APPs. They feel like there's an increasing scope of practice where APPs are doing stuff that they're not fully qualified to do. And then on the flip side, APPs are feeling undervalued despite their increasing responsibilities. Because ultimately, what's the goal? The goal is for the hospital to squeeze out as much money out of all of us as possible, right? So we feel that on both ends. And I think you can create a mutually unbeneficial relationship between physicians and APPs. So, although APPs, I think, are gaining traction because the hospital sees the value in them, that they can get a lot of work out of them for less than we're paying physicians. Physicians also feel like, well, what the heck, they're replacing me. So, yes, there's tensions there, but ultimately, APPs, like I said, are also being taken advantage of. So, realistically, we're all on the same side and we're all taking care of patients. So, I think it would be helpful if moving forward, like we do band together and can fight per se together.
Yeah, definitely. I mean, if we all work together, be each other's assistant, and supplement each other and complement each other work, we can move forward and take care of our patients in a better way. If APPs kind of have that understanding that when to ask for help and for physicians to be available to respond to that, that would be great. But I'm not surprised if one day APPs and physicians get paid the same, because as I said, it's kind of physicians are heading in a very bad direction in terms of compensations. With reimbursements going down, physician
Hmm.
compensation is only going to stay stagnant, and APP's compensation is just going to go higher and higher because there is more demand. And also, we have to, because they have a union, they can set better boundaries and they get paid overtime. I mean, physicians don't get paid overtime. Physicians go home and work on their documentations and nobody pays them. But APPs, they have their set hours. If they work more than 40 hours per week, they bill overtime. So that's a huge bonus. And at the end of the year, you might see actually the APPs and physicians are almost getting paid the same. And all the benefits that APPs get and some physicians don't. So all in all, if we look at the bigger picture, I think we are becoming more equal, in terms of this cost.
Shal, one thing I also noticed is APPs are taking on more leadership roles, right? More so than MDs. Like if you look at C-suites, I see a lot of DNPs on there, a lot of nurse practitioners on there, but not a lot of MDs. And a lot of the NPs and DNPs are women. So women NPs are making this happen for themselves. Yet I see an underrepresentation of female MDs and MDs in general.
Yeah, and I have mixed feeling about that, because I know even in some
Me
companies that
too.
they call themselves physician led. At the end of the day, you see an RN or a previous RN has this higher role and making decisions for you, making decisions of how much time you spend with a patient or how many patients you need to see, the metrics that are placed by them. I mean, it's kind of outrageous, to be honest with you. I'm not a big fan. Basically, RNs in leadership, especially telling physicians what to do and what not to do. And I agree with you that more women are going into these roles. I mean, even I'm sure you've had this like disability or utilization reviews. I mean, the nurse is contacting me, telling me what to write and what not to write, and what to accept and
Hmm.
what to not accept. So it's really, we're losing our autonomy, and they're gaining their autonomy.
That's a perfect way of putting it. And like I said, we have no one to blame but ourselves. So it's good that we're doing podcasts like this. But let's spend the last bit of this episode talking what we think the future of APPs looks like, and what, as physicians, we should consider. I mean, do you think APPs will continue to expand? We already kind of talked about this, but I mean, I think they're just going to, like you said, gain autonomy while we continue to lose our autonomy to a point where it's like, what's the point of being a physician, right?
Right, and you mentioned this a bit earlier, that patients are okay with or happy even to see APPs because they feel that the APPs are spending more time with them. And this goes back to, again, what we were talking about, that they have better support. When an
Hmm.
APP is overburdened, and I talk to my APP friends too, they tell me that if they put a lot of patients on their schedule, they just complain to the union right away. So when they have better support, they can set boundaries and they can spend more time with patients. Physicians are having to spend less and less time with their patients because of all these metrics and productivity, and you just have to see more and more patients. But if NPs are not doing that, and NPs having more time to spend with the patients, so of course the patients will have better satisfaction with NPs than physicians.
And I think because of that, there's going to be more states that will allow for independent practice. I mean, right now we said there's a 5, maybe 27. I can see that expanding in the future because patients love it. The hospitals love it. I mean, why not? It's like a win-win situation for hospitals.
Exactly. I hope that, in terms of leadership, I hope that we see a potential shift where there is a hybrid leadership between physicians and APPs, and it's not just APP mostly going to leadership. But I don't know. I'm not very optimistic about that. What do you think?
The personality of the physician is, I think, how can I say this in a nice way? I think our personalities are we sit down, we put our head down, and we work, right? Whereas they think a little bit more outside the box. They support each other, and they're a little bit more motivated to make change happen. Whereas physicians feel like if it's not affecting them, but if it's affecting their colleague, but it's not affecting them, oh well, who cares? So I think there's a lot of individualism around physicians. So I think APPs will continue to become more and more independent. But I do hope that while they're becoming more independent, one thing that they think about as well is changing their training and certifications to more standardized to lead up to the higher quality of standards that MD programs have. And the reason I say that is, you said right now they're not a target for malpractice, but as they gain more and more independence, and more patients are going to NPs, they will become a target of malpractice. It's only a matter of time. So it's in their best interest to raise their training standards and to make their certification more even across the board.
I agree that you're right. If they become more and more autonomous without physician oversight, then they'll be a target for malpractice because then there's no physician to sue, really. So you sue the APP, and some patients are just, they want to sue, whoever it is. So, yeah, I agree. So that's why I think it's important, as you said, to kind of have some standardization and you know, have a structured team model, versus an independent roles for APPs. I think that would help the overall kind of healthcare system.
Yeah, I mean, look, there's doctors who hate APPs. I know them, you know them. There's people who like
Yeah.
blanket hate APPs, hate nurse practitioners. I'm not of them. I think there's a role for nurse practitioners and PAs in the healthcare system. I've enjoyed working with them, but I do think in this healthcare system, everyone has their own set role. And when people are trying to go beyond their scope of practice to do more, although, I applaud it, like I'm impressed by all of those efforts. I think definitely we should all be striving for more. I do think it does cause some adverse outcomes in terms of patient care, and ultimately we're all here to take care of patients.
Yeah, definitely. Yeah, I mean, I love working with some of the APPs. As you said, there is, for example, there is one hospital, one rural hospital, semi-rural hospital that I cover, and I have only 2 hours in that hospital. Um, so we have an APP there who has a whole day in that hospital. So they pre-round, they see all the new patients and all the follow-ups. And in those 2 hours, they just present the patients to me, all the follow-ups and all the new patients. And I rely on them to tell me which follow-up is not doing well that I need to see with them, because in those 2 hours, there's no way I can see all the new patients and all the follow-ups. And basically I have to trust their judgment, right? I have to trust what they tell me. So I end up seeing all the new patients, and then for the follow-ups I just see which follow-up needs to be seen, and I see them, and then they help with documentation and everything else. I try to educate them a lot. I'm not the type of person who just kind of uses them as
Hmm.
documentation writers, because that's not what they're there for. They're not there to just write your documentations and in this particular hospital, it's a telemedicine, or to push the cart for me. And they don't like that either. So I try to engage them. I try to, go over studies with them. If we have complex cases, I educate them a lot and telling them. Some appreciate it more than others. Some I feel like they're not even listening to me. And they just want to finish their documentation and their work and go home. But some are very interested and show curiosity and show initiatives in knowing more. So again, it goes back to that variability. If you have APPs that are willing to learn and show initiatives and show curiosity, then we can work together, hand in hand, and provide the best patient care together. So I think there is a huge role for APPs in the future as well. I just hope that I can say the same thing about physicians.
Yeah, and we're all doing this for the patient. Us and the APPs are the only ones taking care of patients. Administrators, the CEOs, they're not. So we're the frontline people, and we need to support each other. In a lot of hospital systems, there is a lot of good collaboration, and I hope moving forward that's what we see. But I think we also need to pay attention to real issues like scope of practice, overstepping beyond what you can do. You have to also engage in teaching. So I don't know. It should be a symbiotic, collaborative relationship. Oftentimes, it's not. I don't have a good solution for it, but I mean, hope. I'm hopeful that moving forward, that we can have some informed discussions, better policies, and focus on team-based care. And we'll see what happens. So I think, we can conclude this episode here. We recapped the evolution and the current significance of APPs in the healthcare system and talked about some future directions. I do think I would love for the listeners to explore more about APP roles. And also, if we have APP listeners, send us an email or send us a DM about what your experience has been like. Also, an MD, if you're an MD and you've worked with APPs, we'd love to hear your experiences as well. You can email us at empowermedlife, all one word, at gmail.com. You can send us a DM through our socials as well, just to talk about what your experiences have been, and if you have any solutions to some of the issues that we discussed today. Yeah. Any other final thoughts, Shala?
No, that's great, and we will, bring other APPs on this podcast, and we'll talk to them and see where they're coming from, and their ideas and their opinions. Well, thanks for tuning in to the Be Empowered podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, rate this podcast, and share it with someone who needs to hear us. Stay strong, stay empowered, and we'll see you soon.